from it, I think we should get started. So, yeah. Welcome everybody. It's the last MEC of the year. And I wanted to just talk about something we did as a project over the last year or so. With, of course, it was a team effort, and I just thought we'll talk about it today. So, there, I thought the music will never stop. So I like this favorite quote. My brother uses it all the time in his emails because he runs a IT sort of a business. So there's no limit to what can be accomplished if it doesn't matter who gets the credit, and that's the team spirit. And I know as we are going towards the finals of the FIFA at Qatar this week, I know, I think, did Argentina advance, right? So, and today France and somebody is playing, so I don't know who won. So this Saturday is the final, so we'll see what happens there. But in the meantime, I just thought I'll review some, this will also be helpful for me to review this data because I'm beginning to see, or not always see a lot of patients. Plus, moreover, it's also for the fellows just a good review. So my learning objectives to define primary hyperaldosteronism, utilizing a case of uncontrolled hypertension, actually a case or two, list prevalence, complications, and screening criteria, define the diagnostics, including lab imaging, venous sampling, and to recognize the power of interdisciplinary teams in successful outcomes of the this particular condition. So with the adrenal Santa saying, giving high five. So patient number one, he's 61-year-old. As always, some of the most interesting patients are seen at the VA clinics. And both patients that I'm presenting today are from the VA clinics. So love taking care of veterans. So presence with hypertension, hypokalemia, which he's had since 2012, actually, spontaneous hypokalemia. He also has cardiovascular disease, heart failure with reduced EF, chronic kidney disease, vitamin D deficiency, also hyperparathyroidism, although normocalcemic, which also is interesting because there's some speculation that these two could be associated. Thank you, Kelly. His medications, obesity class 3. I list all these conditions because when you look at the sort of the associations or confounding factors with primary hyperaldo over time, metabolic syndrome, type 2 diabetes, insulin resistance, heart failure, atrial fibrillation, chronic kidney disease, in fact, bone health, are listed, compared to other essential hypertension without endocrine hypertension. These are common associated conditions. His medications, amlodipine, Coreg, hydralazine, isosorbide, and potassium, 80 MEQs per day. Has been using that for the last almost 8 years. He came to us right in the thick of pandemic, and his labs as listed here. So I know Dr. Winters will be there telling where are the units, so I had to make sure I have them. His potassium, as seen here, and 3.3, 3.2, and this was in spite of replacement. And glucose, actually, interestingly, when we first saw him, he'd also been admitted to the emergency room with a blood sugar over 800 and just been diagnosed as type 2 at that time. And creatinine, as you could see, and definitely a random renin and aldosterone levels repeated at 2 different occasions. And his CAT scan, which was done after that, showed nodular thickening of the left adrenal and perhaps adrenal. I don't know if I have the picture from here, but may not. So patient number 2, that's patient number 1. Patient number 2 was a consult from nephrology, again at the VA. 45-year-old, past medical history of hypertension since his early 30s, actually. So probably 32, 33 when he was first diagnosed. No family history, however. And he has obstructive sleep apnea, renal calculus, and obesity. And he had an incidentalloma, which was seen on a CT scan in the setting of uncontrolled hypertension and hypokalemia. So of course, was sent to us from renal attending for hyperaldo evaluation. His CAT scan, though, did show he had an adrenal adenoma, which was pretty clear-cut unilateral. So that's the second patient. And of course, he had 100% washout and 1.5 centimeters, 10 HU, so pretty benign appearing. So, and his medications, amlodipines, he was already started on spironolactone by renal just because his blood pressure was so high and he was struggling with the low potassium. And he was also on ARB, 320 milligrams. And his renin aldo levels here repeated at 2 occasions, as you can see. 24.9 was this nanograms per ml per hour. So the renin and the aldosterone nanograms per deciliter. So already mentioned he does have a classic looking adenoma. So and these are his electrolytes here. Usually you expect alkalosis, which he does have in some areas here, but he's also acidotic occasionally and pretty severe hypokalemia, and which has been very troublesome for the patient because he's the breadwinner in the family. So I'll leave the patients, they will come back to them and share with you what we did. But can't talk about primary hyperaldosteronism without paying tribute to Dr. Kahn, Jeremy Kahn from University of Michigan in Ann Arbor, who was a pioneer and who first described this syndrome in 1950s. And he also did a lot of extensive work on heat acclimatization and hypothalamic pituitary axis, spontaneous hypoglycemia, interestingly, and in the area of diabetes. And he first described the syndrome and he collected series of cases and was very visionary at his time in terms of the prevalence, which I'll come to in a second. So also it's interesting when you talk about mineralocorticoids and glucocorticoid receptors to talk about evolution. It becomes very important. And that is evolution from ocean life to human life or to land. And I bring to you the fish here. Does anyone recognize this fish? Sorry?
Looks like a catfish.
Actually, it's a salamander or lungfish. It's one of the few fish that can live in ocean and also on land, even up to a month, because it has both gills and lungs. So it's called lungfish. And it has been used as the example of the first living being as synthesizing aldosterone because of the necessity of having to move from a very salty environment of the ocean into the land. So you had to develop certain ways of compensating and accumulating salt, and that's how aldosterone sort of developed. So, which I found was very interesting. But it took us a while actually to clone the mineralocorticoid receptor in almost, I think, 1980s. So it's been over 40 years since it was cloned. But the aldosterone, initially there was just a generic steroid receptor, and then later on, as we needed more sort of requirement as progesterone receptors and glucocorticoid receptor, and of course the mineralocorticoid receptor. And so there's a high affinity. That's why when you talk about mineralocorticoids, there's also a high affinity between cortisol and aldosterone and the 11 beta HSD, which we have to underscore that. So, and as I mentioned, the receptor was later cloned almost 40 years ago. So I thought this was a very interesting fact. So that brings us to the physiology of the renin aldosterone sort of mechanism, or the RAS axis. And it's a very interesting, there's a renin-dependent and a renin-independent mechanism here. And in the setting of when there's volume loss or dehydration, there is stimulation of the juxtaglomerular cells, which secrete renin, which then initiates the activation of the RAS system. And the ANG2, or the angiotensin 2, is very crucial because it stimulates, it's sort of has a vasoconstrictor effect, maintaining blood pressure, and it acts as an important role in counteracting the volume depletion. And ANG2, it increases sodium absorption into the PCT, and also it it helps with the delivery of sodium into the distal nephron also. It decreases the delivery. So aldosterone is controlled in a way by ANG2, also ACTH, and your potassium. Those are the three powerful mechanisms of control for aldosterone secretion. So the mineralocorticoid activation in the principal cell, which is part of the PCT and the loop of Henle principal cell and the DCT. So this sort of results in the epithelial sodium channel mediated sodium resorption. And the net effect of this can maximize more sodium absorption and increase the volume, circulating volume. And like I mentioned earlier, ACTH also has an effect on this. And there's an independent mechanism, and that's extracellular hyperkalemia. When potassium is higher, that again triggers aldosterone sort of activation, and that decreases or excretes more potassium into the urine and activates the MR, and again sodium resorption through the MR, the ENAS mediated sodium resorption. So this is sort of a very tightly controlled mechanism. And when there is hyperaldosteronism, or when there is some autonomous mechanism in the aldosterone, which is independent of renin or which suppresses renin, as you can see here, completely suppressed renin and angiotensinogen. And here the primary problem is there's increased stimulation of the mineralocorticoid receptor in the principal cells by aldosterone, independent of ANG2 or independent of potassium, and that expands, that again results in inappropriate sodium absorption, and this sort of sets up a vicious cycle, and that causes hypokalemia and the subsequent mechanisms that we see, including metabolic alkalosis that we see here. So that brings us to the definition of hyperaldosteronism. It is, in the past, we had a very simple definition, but over time, more recently, given we look at it as a spectrum of disease rather than just one condition that you diagnose in less than 1% of population with hypertension. So we call it suppression of baseline renin secretion as the definition, and increased fluid expansion, specifically in effective arterial blood volume, and again, also inability to stimulate renin secretion normally. So there's a baseline suppression, and also there's inability to stimulate renin normally, and inappropriate and unsuppressible aldosterone production. And this could also be present in a normotensive state, and this sort of expands the spectrum of when you start looking for a diagnosing primary hyperaldosteronism. So how do we screen for primary hyperaldosteronism? Well, for that you need to know the AHA, ACC, or WHO, European Society of Hypertension guidelines for normotensive and hypertensive individuals. Normal blood pressure, less than 120 systolic, less than 80 diastolic. Elevated, but not hypertensive yet, is under 129 and under 80 still. Stage 1 hypertension, 130 to 139, 80 to 89. Stage 2 is over 140 and over 90. The European and WHO have a third grade also of a higher number, but for practical purposes, we'll go with the AHA guidelines. So given the blood pressure readings, who do you normally sort of screen? Well, before I could even go into the guidelines and look at it, I was able to Google and find this Primary Aldosteronism Foundation. I knew about the Addisons, I knew about the adrenal, I didn't know such a foundation existed. This pretty much gives you everything, all data that you need to know about primary hyperaldo. And it pretty much tells you whom to screen, how many are there, how many will you diagnose, what are the complications, who should they call, etc., etc. So it's pretty interesting. Also lists the adrenal centers. So that brings us to prevalence and screening. And prevalence, again, depends on how you define the disease. And like I described earlier, the definition now has changed over time. So when you start looking at the traditional guidelines, it talks about moderate to severe hypertension, and the prevalence rates are 1% in any hypertensive if you look at them, or stage 2 about 8%, stage 3, which is severe hypertension where they need 3 or more medications, 13%. That's how high the prevalence is. So, and also resistant hypertension, which I mentioned earlier, on 3 hypertensive meds, and with spontaneous hypokalemia, which was the classic or the sort of the most essential feature, but we don't describe it that way anymore because we all know about 7 to 30% will have hypokalemia, but the rest don't. They're all normokalemic. Hypertension with adrenal incidentaloма, which was one of our patients, and which was incidentally performed for other reasons. And then hypertension with obstructive sleep apnea. And in this criteria, you could also include all those other comorbid conditions that we talked about. Diabetics, there was a study by Umperis in 2009, I think, looking at type 2 diabetics with resistant hypertension, looking at the prevalence of PA, primary hyperaldo. It was about 14%. And if you look at our group here of severe hypertension, it's about 14%. So it's important to sort of look at which groups and how it's, and the spectrum I spoke about, which was recently in the last 5 years described, looking at sort of tip of the iceberg and how many more patients there are that could be screened. And that includes actually normotensive patients without overt primary hyperaldo and normotensive to mild hypertension, and sort of talks about where you could have non-functional hyperplasia, which sort of progressing to adenoma over time, and you want to get them very early. And internationally, many other institutions have and countries have started doing that. So this is one example of that kind of a study. This was a 4 academic center study, which was published in Annals, very interesting. And the Brigham team, adrenal team, was the main PI. And they looked at pretty much normotensive, untreated mild hypertension, and then untreated stage 1, stage 2, and treated resistant hypertension. So these were patients that were being followed in their clinics, I think 3 in East Coast and 1 somewhere in West Coast. And many of them were on 1 or 2 meds, and in the study, they were able to stop the medication. They liberalized their salt intake, gave them enough sodium so that when they collected a 24-hour urine, their sodium output was almost 200 millimoles per 24 hours. And then once they did that, they sort of did a salt loading test to look at, and then one of the confirmatory tests, saline load or salt load, and looked at renin aldosterone levels and 24-hour urine aldosterone. They didn't want to measure aldosterone at one point. They did a 24-hour urine. And they looked at how many of those patients actually had fit the criteria for primary hyperaldo based on a urinary aldosterone of more than 12 milliequivalents. Interestingly, there were about 11% in the extreme end of the spectrum, which is normotensive patients, and then 22% in the resistant patients. And none of them had the classic hypokalemia or high aldosterone or very suppressed renin. So that sort of brings us to the fact that many patients we may be missing, or we may be able to sort of diagnose much earlier than we thought we would. So that expands the indication to any stage 2 hypertension and anybody who's normotensive also. So why is it that we have to sort of do this? Why should we be so aggressive? Well, the effects of long-term primary hyperaldo are quite powerful. So that's very important to sort of, find them early. And this is a study looking at composite cardiovascular events such as, MI, stroke, heart failure, hospitalizations. And they looked at patients who had essential hypertension, which is no endocrine hypertension, and those with primary hyperaldosteronism who had been treated with adrenalectomy, and those who had been treated with oral agents, MRA antagonists such as spironolactone or eplerenone, to bring the renin over 1.0. And then those who were treated with MRA because they were not surgical or we don't know why, but their renin was not higher. So when you look at outcomes over time, so the highest prevalence of the highest composite cardiovascular outcomes were in those patients whose PRA or renin activity was still suppressed, as opposed to patients who underwent surgical adrenalectomy. So it is important to treat it and to treat it right. So how do you prepare for these patients? I know most of us here have read the guidelines and know enough about this, but I just thought I'll sort of breeze through it. Most important is make sure they're all normal kalemic when you start screening them, which about 70% of the patients we suspect are normal kalemic to start with. They don't have spontaneous hypokalemia. And next thing is to make sure that they're on certain medications, which our fellows can list all of them in their sleep, but like birth control pills or hormone replacements, in gender-based looking at patients. Any estrogen containing medications will lower direct renin activity or direct renin concentration and can cause a falsely positive ARR. And if DRC is used, which is not relevant to our group here, we do not use renin concentration. And also, if you're going to stop the birth control, make sure that you have alternative. You don't want to screen patient and then find out they got pregnant in the process. So age, older the patient, renin can be lower. So that also, again, tends to raise your ARR. Gender, again, like I mentioned earlier, birth control, and certain times such as luteal phase of the cycle, sometimes you could have false positive. Time of the day, which we talk about it a lot, you can't do it, like usually I remember when I was a fellow, Dr. Winters would say, go down, walk up and down, come back, and then we'll measure it. So posture becomes very important. And diet, heavy salt load. You want them to be on a normal salt diet. You don't want them to cut out salt for 2 days and then come for the visit. Then you'll miss the bus. So, and also method of collection, and also temperature and kidney disease can again cause false positive ARR. Medications, there's a huge list of medications that can interfere, either increase or decrease the level of the ARR ratio, so it's very important. Most important to know is mineralocorticoid receptor antagonists, the spironolactone or eplerenone, or ENAS amiloride, those kind of medications, renin inhibitors. Those need to be stopped much earlier, especially spironolactone for 6 weeks or so. But all others, up to 2 weeks, usually works just fine. And medications that are recommended to be used while screening, typically calcium channel blockers, especially non-dihydropyridine, such as verapamil. Hydralazine, we use hydralazine a lot. Alpha blockers, taxosin, prazosin, terazosin, and of course, there are limitations to this, postural hypotension, and some patients with heart failure, we have to be careful what we do with that. Very important to remember, beta blockers do lower your renin levels, but many times if you can't stop it, you can't. So like I mentioned earlier, spironolactone has to be stopped at least 4 to 6 weeks ahead. However, there was a paper in 2014, and subsequently the 2014 paper was from Munich, Germany, and subsequently where they had series with spironolactone on board doing the adrenal vein sampling. They were able to get good results, mainly because in spite of being on MRA, the renin was undetectable. So in that case, it's okay to keep them on it. So what are the cutoffs? Again, that is a very a matter of a lot of discussion. While we all agree renin suppression or having an assay which has renin suppressed or PRA, plasma renin activity, is important. In terms of the aldosterone levels, how low is low or how high should you go? Well, you look at studies over the last 20, 30 years. when you use a cutoff of 10 versus cutoff of 7 or cutoff of 15, you get varying results. But the consensus now is to try and use as much as possible levels of aldosterone, even if it is as low as 7 or 10, still to use it if the ratio is acceptable. And these are different. It's important to know the assays that is in the center, and we are fortunate to have plasma renin activity and PAC available. And using these are the ratios, ARR ratios that are used as cutoffs, and using direct renin concentration, which I haven't ever used it, so I'm not sure how that works. And this is picomoles, and this is nanograms per deciliter, and these are your ratios. So once the ARR ratio is established and you have a certain ratio, the next step is to go to the confirmatory tests. And the patients who do not need confirmatory tests are those who have spontaneous hypokalemia, pretty severe hypertension, and aldosterone levels at least over 20 nanograms per deciliter. Those usually do not need. You could go directly to the next step, skip the confirmation. The rest of them, we have to mostly try and do the confirmatory tests. The ones we do in our center here is saline infusion test. We have a good setup in the VA. Our nurses have a protocol. It's been approved, and we do have the same that we use in the infusion center here. And the sensitivity, specificity, I've listed them. And the captopril test, I have no experience with that. Perhaps Dr. Mokshagandam or Dr. Winters may have some comment about it. Fludrocortisone test, again, sensitivity 87 and 95%. Oral salt loading, which is the test that Mayo Clinic uses. It's a pretty popular test. They do it because many of their patients are staying in the hotel anyway, traveling from outside. It's easier for them. You load about 6 grams of salt every day. It's like eat all the potato chips you want or pickles you want for 3 days. And they confirm the sodium load is adequate by you doing a 24-hour urine. And then they then do a 24-hour urine aldosterone, which the cutoff is 12 micrograms. And here again, the sensitivity 96, specificity 93%. Let me stop that. And once it's confirmed, and we know for the saline load, let me just go back to that for a second. Saline infusion, aldosterone level more than, we use 7 to 10 as the arbitrary number. Some places go as low as 5, but 7 to 10 or 10 or above is pretty confirmatory. Oral salt loading, I mentioned 12 micrograms per 24 hours urine. The fludrocortisone suppression, PAC over 6 upright. And the captopril challenge is a decrease in about of the PAC by less than 30%. Saline infusion, one other thing, many of our patients sometimes are not able to sit the whole 4 hours, but there is a caveat where you can tell them if you want to lie down, and then we use a more sort of a tighter cutoff than if they want to lie down for 4 hours. Sometimes they just can't do the sitting the whole time. So that's important to remember. So, and once it's confirmed, then we go to the next step, and that is where it's important to be either part of a good adrenal vein sampling center or have something available as close as possible. And and the vein sampling is mainly done once the confirmation is obtained for primary hyperaldo to mostly lateralize, so you could decide whether this patient needs surgery or not. If somebody tells us, I will never ever have any surgery, or if they're very poor surgical candidates, which the risk is quite low, so I can't imagine a whole lot of patients who can't undergo the surgery. But if they absolutely say, no way, even if you do this, I won't go for surgery, then it's not advisable to go with this sampling because it is an expensive procedure. Depending on which part of the globe you're in, it could cost anywhere between $2,000 to $20,000. And I don't know how much it costs in our center, but that is sort of the going rate. So it's important to sort of make that clarification with the patient. And the sensitivity and specificity of adrenal vein sampling. is about 95 to 100%. Well, I skipped an important step. Our patient came with CT already, so I forgot to mention. But normally, if you are going by algorithm, the next would be actually an imaging procedure, getting a CT. MRI is not recommended. CT is actually much better in terms of definition and everything. But certainly you would need some kind of imaging done of the abdomen, preferably adrenal CT. And irrespective of the CT scan results, mainly because our patients are mostly in the 50s and 60s, and I'll come to that in a second, who gets adrenal vein sampling and who doesn't. If you have a patient who's under 35 years old, has a unilateral, very clear adenoma, and on the CT scan, has spontaneous hypokalemia, then with hypertension, then pretty much no need to go to the adrenal vein sampling. They could easily go ahead and get surgery done at that time. It's Conn syndrome, that's what we call it. Used to be 40 or above, but slowly the age cutoff keeps going down, and now it's at 35. So, however, one would argue that why is it if the CT shows a clear-cut evidence, such as our second patient, and they have sort of undisputable hyperaldosteronism, why should you go to this very expensive procedure which requires a center? Well, there's the data for that. So the sensitivity and specificity, and also if you there's this study from about 950 patients, and this is again published in Annals of Internal Medicine about 10 years ago. They looked at patients once they have had the evaluation done and once the treatment was done, they went back and looked at if the patient hadn't been through the usual process, what would happen? Well, turns out in most of the patients, at least 40% of them, the CT scan or the imaging results didn't agree with the adrenal vein sampling, which means if they went ahead and went with that unilateral tumor and PA diagnosis and went for surgery, 40% of the time it would be a wrong diagnosis. That's number one. And 40% did not agree. And then 15% would end up having an inappropriate adrenalectomy for a bilateral problem. It would end up having a bilateral. And then also adrenalectomy on the wrong side could have occurred in 4%. So those were the reasons that you need to go for the adrenal vein sampling as the next step. So what are the keys to successful AVS? Appropriate patient selection, just like we talked about. If they don't want surgery, no need to go that route. Careful preparation, just like we talked about earlier. You want to make sure their normotensive potassium is normal, and a well-defined protocol, which we'll go into in a bit, and data interpretation, and most importantly, also good clinical chemistry setup. And the rates, depending on the centers, can be anywhere between 47% to 74%. And in some of the top centers, such as Mayo and in Munich and Ann Arbor, their rates are almost 95% or above. And that's what we want to make sure that we have. And what is the tricky part? Why is it that any interventional radiology can just go on and do this procedure? Well, it's important to know about the anatomy of the adrenal vein so that you understand why it's important to have somebody with expertise in this. So we have the right adrenal vein here, which this is the left one here and the right one. So the left one sort of goes with I probably use this very clear. The right adrenal vein, if you see, it's a shorter vein, number one. It's a very obtuse, sort of very abrupt course. It goes directly. Whereas the left one, it's a longer course and it shoots off the renal vein. And many times, the right adrenal vein could be confused when they're putting in the catheter. They can, by mistake, go into the hepatic vein and think that's the adrenal vein. That can occasionally happen. So that's why you need a lot of expertise for those procedures. And Also, sometimes there may be anomalous vein anatomy, so that should be, the angiographer should be familiar with what can happen with the embryo and the change of the veins, distribution and everything. So it's important to have somebody who has experience in this, and also the right kind of catheters that they have: the Cobra catheter, the Bernstein catheter, catheters with side holes where they can draw the blood. So those kind of stuff. So that is all very important, highly skilled, and a return protocol, which I'm happy to say our protocol is hanging on the interventional radiology lounge wall. So that's what the chief tells me. So, and it needs to be a group of interested endocrinologists, radiologists, and lab personnel, which we do have here, and safeguards for mislabeling tubes in the radiology suite and any mix-up of the lab. So there is a lab runner, and when the first time the procedure started, the then fellow and now junior faculty, Zach Sibai, was there for the first few procedures, even when surgery sent it, so that he could help them sort of label and help them place the orders and everything. So as I mentioned earlier, discontinue the mineralocorticoids and blood pressure control and the right kind, and then alert the chemistry a day ahead of time. So they need separate personnel available just for this to run everything, and the machine has to be available. And when we're doing this, we also use cosintropin infusion, and mainly for a particular reason, which I'll tell in a minute. And it's important to also have a lab. They are able to dilute the cortisol and give you the accurate readings, which is diluted almost 50 times over, which our lab fortunately now is able to do that. Because when you go with the catheter, you draw labs from the IVC or external iliac vein, then the right and the left adrenal vein, and then the cortisol levels sort of give us an idea as to correct placement, and I'll go through those nomenclatures in a second. And as far as complications go, the complication rate in very experienced centers is less than 2.5%. Groin hematoma, rarely adrenal hemorrhage, and dissection of the vein. So why do we use cosintropin infusion? Some places use bolus infusions. Some places we give it as continuous infusion. We started using bolus, and now we are going to continuous for a particular reason. So cosintropin is mainly given to, why can't we just directly measure cortisol, aldosterone, and do a ratio? Why do we need to add cosintropin? Well, the stress-induced fluctuations with aldosterone secretion can be minimized during the non-simultaneous AVS. Like when you're drawing one side, the other side, patient starts getting stressed, the level can be inappropriately higher. And also to maximize the gradient from the cortisol in the adrenal vein to the IVC or the external iliac, so we can confirm the sampling was successful. And also when you stimulate with cosintropin, as we all know, ACTH does stimulate aldosterone release. We want to maximize, if it's a aldosterone producing adenoma, maximize the sort of the aldosterone production from that. So next comes the indices that we use. Selectivity index is the one that we use to look at, is it correctly cannulated? Has the cannula gotten into the adrenal vein? Lateralization index, at this point, we decide which side is more dominant, or is it just a bilateral adrenal hyperplasia, in which case no more surgery. Contralateral ratio, we haven't used much here, or haven't had to use much. So the ratio for the aldosterone from high to low, which is the lateralization, for definitely having aldosterone producing adenomas 4 or above, and dilution, which is the cortisol from the IVC to that, is 5 or above. Majority of the patients, it would be like at least 20 times more, 100 times, 30 times more sometimes. So, let's see. We talked about the lateralization, 4-to-1 versus, and if it's 4-to-1 or above, you can be very sure it's a aldosterone producing adenoma. With idiopathic hyperplasia of the adrenal, it is usually the ratio is less than 3:1, which it is bilateral, or if it's unilateral but it's hyperplasia, then it could be sometimes about between 3 and 4, but not exactly 4. So those are the different. So what are the different sort of outcomes when you do these procedures? Well, in classical hypokalemic hyperaldosteronism, 70% of these masses end up being aldosterone producing, and 30% end up being the idiopathic adrenal hyperplasia. Normal kalemic hyperaldo patients, 40% is aldosterone producing solid unilateral adenoma, 60% can be IAH. Less than 1% in both these conditions will be either glucocorticoid remediable or macronodular adrenal hyperplasia, which is again very rare. So this time I have to thank the whole team that helped us here set up within the last year. We didn't have it for a few years now, and we had restarted, and it did take a lot of effort, both from our fellows and then the interventional radiology team, Dr. Barr, Dr. Contractor, and also the administrators and nursing administrators there, Stacy and Andrew, and the clinical lab team, Dr. Jotani, and then Anna McGuffin. She's been great help there. And informatics, of course, to set up the order sets so that we could get it running in Cerner, and that's Dr. Dews and Dr. Siegman. And of course, we always need great surgeons to sort of work with these patients, and we are fortunate to have very good endocrine surgeons. So our patient number 1, the right adrenal vein and the left adrenal, so let's see, IVC, aldosterone, IVC cortisol, right adrenal vein, cortisol, and aldosterone, and left adrenal vein. Thank you, Rahul. You did the calculation on this one. And his ratio left to IVC. So he definitely the most difficult, one to cannulate, like I said, is right. And we got it right here. I mean, was able to cannulate the right. So 35 is the ratio. And as I said earlier, 5 or above or 10 or above is good. And left is 11.7. And then the ratio of dominant left versus right was 7.7. And this again is over 4. And so this patient successfully, patient number 1, did lateralize. And so that was a great thing. So he underwent, so these are his numbers here, his electrolytes. And I have to say, sort of a month ago, more than a month ago, he did undergo Dr. Egger, left posterior retroperitoneoscopic adrenalectomy right here. And you could see already his creatinine was 1.92 before that. And we've been sort of every 2 weeks doing telemedicine with labs with him. And when he went for the surgery, we had to add spironolactone. His blood pressure was too high. And then right after surgery, he got the spironolactone stopped. And when he was sent home on half of the potassium. But guess what happened? Just with a half of whatever the surgery team decided to, he became hyperkalemic, so we had to stop all the potassium. And of course, these are his current, not even half. He put him on 25% of the dose, so which I think was 10 or 20. So, and right now he's just on hydralazine. He's on empagliflozin for his diabetes, very small dose. His A1C is like 6.4% from having blood sugars of 800s in the past. And then, and just AMLO 5, hydralazine 75. Even this, we are trying to wean him off. And that's it. Those are his meds. And also, I think he's on Corec. So this is his pathology. This is the macro, and this is the micro. The comment was a micronodular and diffuse adrenocortical hyperplasia. He's doing quite well. And the surgery he underwent is the laparoscopic adrenalectomy. Not many surgeons in anybody can do that. You need specific expertise. And surgical mortality in a case series of 300 patients done, it's a 15-year series, showed 0% mortality, infections less than 1%, hyperkalemia, if you're careful enough and stop all the meds, very, very unlikely. Adrenal insufficiency, we did not see in our patients, but apparently need to be watchful for that. So that is a successful story. And what are the sort of the right kind of patients, and how do you measure outcomes? Well, this is a study from 12 centers across 31 countries, which was published about 5 years ago. And you can see some of the centers here: Torino, Italy; Brisbane, Australia; Paris, Japan; Berlin, and then you have Rochester here, and there's Warsaw and Munich. So a lot of centers in Germany. So the outcome showed that, so first one was clinical outcomes, and the second is biochemical. Clinical meaning better blood pressure, better, like less blood pressure meds, improved weight, which surgeons sometimes tell them you will lose a little bit weight also, which it could happen because they're fluid overloaded, and CV outcomes. And the biochemical is renin unsuppression and aldosterone getting lower. In younger the patient, women, interestingly compared to men, and those who are on less medications to start with, which means stage 1 hypertension or very mild hypertension, not resistant, were more likely to go into remission. And then what is the percent of remission? That's very interesting. And this is the PASO study, primary aldosteronism surgical outcome study that was done. And complete remission, which is no medications at all, potassium is normal, nothing, is 37%. Partial is about 47%. No change at all is about 16%. And this is the clinical outcome. Biochemical outcome, complete is 94 with adrenalectomy, and partial is 4%, and absent is much less. So let's see. And like I mentioned earlier, women, younger women and less number of meds did much better. And that's why it's important to find them much earlier rather than wait later when they have developed already multiple complications. Adrenalectomy improves CV outcomes, as we showed much earlier in the thing. It does improve. One study by Rossi's group from hypertension showed that it does improve sustained reduction in LV mass due to decreased LV diameter and volume and workload. And it does also improve carotid intima media thickness and arterial stiffness in patients with unilateral PA. That was shown almost 10 years ago. And also reversal of microalbuminuria, which we obviously, improving chronic kidney disease. And also significant improvement in quality of life by 3 months, and it's sustained in 6 months, and that's also been shown. So patient number 2, you would be curious to know what happened with him. Patient number 2, the younger gentleman with a unilateral adenoma and controlled hypertension, sleep apnea, kidney stones. Well, these are his values here, and these the catheter was in the right place. Selectivity index was fine, but the lateralization was just 3.75, which is sort of unfortunate in this case, because he was the one we were just hoping that we would be able to, sort of get the right outcome. And if you think back, his hypertension started when he was in his early 30s, and he had this unilateral adenoma. Nobody scanned him at that time, so we don't know if he had adenoma at that time. So, but certainly he may have been hypokalemic already. So literally he could have been Conn syndrome and had surgery 10 years ago. But now when we do that, and it's very possible that he has bilateral sort of disease now. He's not below 3, he's not above 4, he's between 3 and 4, which sort of goes along with probably hyperplasia at this time. So he is on other medications, the spironolactone. We had to put him back on it, and then he didn't tolerate it very well. developed gynecomastia, which I'll talk about the data about that, and then had to go on and then go to amiloride. But he's doing better. He went on keto diet. He's lost a lot of weight and being positive about it. So, let's see. So that brings us to medical management, which is what he's on. And the most successful way to do this is to make sure the renin is unsuppressed or the renin levels come up. And that's sort of a way they may have almost closer sort of effect to the way it is with adrenalectomy. So that's very important. So here you can see the MR antagonists act here. And also, so this sort of improving their or sustaining their potassium absorption and sort of causing the sodium natriuresis is very important in these patients. And let's see. So aldosterone is a non-selective antagonist, so there's definitely problems because it has agonist activity to progesterone receptor and androgen receptor too. So many of them do have uncomfortable gynecomastia, ED, and women tend to have menstrual irregularities. And the lower doses, gynecomastia is about 7%. The highest dose, like around 150 milligrams, it's as much as half of the patients have it, and it's very uncomfortable. And at that point, we either move to ENAS channel agents such as amiloride or to eplerenone. Eplerenone is selective, so none of those sort of gynecomastia, but however, very expensive, hard to get it approved, and also not as powerful as spironolactone. And definitely, if adrenalectomy or if AVS and if there's lateralization and if adrenalectomy could be performed, these patients do so much better than MRA based on one other study where it showed that patients who had, they had lower incidence of atrial fibrillation if patients underwent adrenalectomy compared to MRA. So other medications, there's the newer one in diabetes to improve chronic kidney disease, finerenone, which is a newer agent. It's a sort of a but it's a selective agent. However, there's no data in hyperaldosteronism. And I know Dr. Rawal was going to do a journal club on the newer aldosterone synthase inhibitor, which they've tried, been through different studies. So far, we don't have one that has gone to phase 2, and finally we have one. But when I reviewed the data, there was no hyperaldo, while they didn't exclude patients, but there's no specific actions on hyperaldo. It's mostly for resistant hypertension. So at this point, we don't have a magic selective receptor antagonist with minimum side effects, cost-friendly, or aldosterone synthase. And maybe it will be baxdrostat, we don't know. So we have to wait and see. There's been more recently now with the SGLT2 and with the GLP-1 sort of advent, one wonders, especially given that many of these patients do have metabolic syndrome and diabetes and insulin resistance, sleep apnea, one wonders if there's any effect of SGLT2 or GLP-1 on PA, and very preliminary studies have not shown any major effect. They can sometimes, because of the slight volume loss, there could be a slightly higher sort of ARR with SGLT2. With GLP-1, when they did studies, animal studies doing the acute infusion, there was a lower aldosterone effect, but long-term, the GLP-1s we use are weekly or daily. There's no real impact. The impact seen was related to weight loss, which is independent of the hyperaldo. So that is about those two. Then the final sort of statement about familial forms, because one has to mention, and who are the patients with PA whom you do genetic testing? Well, they're quite young with our pediatric colleagues here, less than 20 years old, certainly yes. Family history of PA or stroke at a very young age, such as younger than 40 years, definitely, with hypertension, definitely need gene testing. And also for looking for familial hyperaldo type 1 and young patients for germline mutations, which is KCNJ5 gene, which comes often in the boards for type 3 familial hyperaldo. So, and anybody with familial hyperaldo type 2 and 4 has to undergo AVS because they could be successfully treated with unilateral adrenalectomy. And also there's this other gene, CLCN2. I know Dr. Clark, if she's on the talk, would be interested in this germline heterozygous mutations, which they talked about during the Endocrine Society. So finally, this is a simplified algorithm from Endocrine Society 2016 guidelines, where they talk about detection, confirmatory testing, imaging, and sampling. Lateralized, go for surgery; not lateralized or not agreeable, then go for medications. Well, there's an update within the last 4 years from Mass General, which is a bit more complicated because they include this whole spectrum of normotensive individuals, and they try to do this sort of description of this, sort of getting those patients early. They even speculate talking about if you cannot control the blood pressure using regular agents and with mineralocorticoid and they have complications, even consider doing partial adrenalectomy or sort of idea, which I couldn't find too many studies for that, so I did not want to present that information. But this is more of an expanded algorithm looking at more, and definitely all our patients, we have to talk about dietary sodium, given amount of sodium there is in all our diet. So anyway, so that sort of concludes my brief talk. And thank you everybody for being here today. And I wanted to share the event code and thank everyone. Dr. Any questions? I know, I'm trying to stop the music, it won't. That's okay. I'll minimize it. Oh, she entered the CME code. There's no question so far. Okay. Oh, thank you, Doris. Mm-hmm.
Put the number of people with hyperaldosteronism and
Yeah, I counted the zeros, and I think that's pretty much. I'm not sure. Maybe they're including all these normotensive sort of 11% with no blood pressure as to. It's a pretty big number.
Yeah,
Mm-hmm.
that question.
Yeah, just so. Mm-hmm. Mm-hmm. Yeah. So this year at the Endo, I don't know if you were at that symposium. They had the academic group from Monash University from Australia present their data. They don't just sort of wait for the referrals. They sort of have a collaboration with the primary care groups in the community everywhere. And they aggressively screen patients very early and accumulate them. And they do, somebody was presenting and looking at the, sort of percent prevalence. It's pretty high when you start looking that way. It's very early. And if you looked at the data from the PASO study, looking at the surgical adrenalectomy outcomes, and when they broke down, which didn't have time, so I didn't go over the different age groups, in the United States, our age groups are older patients, like Brisbane, that area, much younger patients, and their success of sort of clinical outcomes and biochemical outcomes are much, much higher compared to some of the other places. So So I think it depends on what cutoffs they use with the aldosterone, whom they screen. The more you start screening, you're going to find more of these. And, how skilled everybody is over there. What the outcomes long term. But some of them look very powerful in terms of, looking at the atrial fibrillation. And there was a Cali cost study, which I didn't present, very interesting, how much you saved in a lifetime when you had this done on time. It was pretty impressive. It was like more than some thousands of dollars, like 100,000, 400, 500,000. So when they went through it versus didn't go through it, sort of thing. So
For normal cancer?
no, just as a whole for PA. No, not for normotensive. No, this was more like a cost effectiveness of screening and undergoing this in a center as opposed to not going to a center. So, but certainly it's very interesting. So, sorry, you had a question?
Yeah. Hi. Thanks for a great talk. I may have missed it. This is Swapna.
Hi, Swapna.
Hi, how are you? Thank you for the talk.
Good. Oh, thank you for being there. Go ahead.
So, if there is no CT evidence of adrenal hyperplasia, it just is a normal CT with no adenoma or hyperplasia, does the ABS help at all?
So, yeah, that's a very good question. So, they talk about, which I did when we had a patient a few years ago, and I remember talking to Bill Young when he was here. And when you look at some of the pathology specimens, they could have really micro nodules, which may not be very clear on CT. So they still recommend, if it's a very confirmatory case, to go ahead and do it if the patient is willing. So, I mean, all you're trying to do is lateralize. And if you cannot lateralize, it's probably bilateral idiopathic, in which case you're going for medical therapy.
Okay, so
they do recommend that.
Expensive procedure for...
Yes, you're right. Expensive, a lot of preparation, and you need a very skilled... I mean, we are fortunate. We have somebody. I had listed and kept patients for the last 2 years and tried to engage them. And finally, now we are slowly sending them. And I think surgeons are, and I'm sure I recall somebody from Norton also sent. I wasn't sure who it was. So we are now. But, if you don't have a center, and then I had to tell the patient, can you go to Ann Arbor or Mayo, and how many people can afford to go there, right? I know at least few people, 2 or 3 that I know of who went, but most can't afford it. And, I even talked to Dr. Young and said I had like 6 or 7 patients. He said, well, they all come one night, we do the sampling, and I send them back. You don't need to, because the surgeons, we have great surgeons, so I had to send them there just for radiology. But now we don't need to do that anymore. No,
perfect. And I have one more question if I have time. So if you have somebody else, you can take.
Go ahead.
Okay. I have a confirmed case of primary hyperaldo with a botched ABS. The ABS was done incorrectly. And so I've been, like you said, I've been holding on to this patient, and I can't seem to get him to tolerate the hydralazine and other things. But, I guess, interestingly, he's got a lesion on his one adrenal gland, which is not an adenoma. It is a myelolipoma, which I think it's about 6% or lower of myelolipomas that actually secrete anything. So, so if you have, now the expertise, I'd probably want to go ahead and send this guy, because we've been waiting on him to, I know we didn't have good, and this was done, I hate to say it in the city, but incorrectly, the AVS sampling about a couple years. So I'm a little hesitant to send him back. At the same time, he is not, he's on eplerenone, and I haven't had trouble. Eplerenone, I've not had any trouble getting it, but he still has high blood pressure, and I would really like to do a lateralization study. So you think he'd be somebody the team would take on?
Oh, absolutely. Yeah, we can talk offline. You can give us the details. Yeah, definitely.
Right. And then, so you probably don't have much data on this, but adrenal myelolipoma and primary hyperaldo, off the top of your head, do you know much about?
Yeah, interestingly, somebody, I think one of the surgeons did ask me a couple of years ago about this I think, I don't know, maybe it was your patient or maybe someone else. And I can't recall what I found at that time, but I can get back to you. Dr.
Okay.
Mochiganam, do you know anything about myelolipoma? And Dr. Winters, I don't know if he's still there, but certainly I think this came up and I remember looking it up, but I'll get back to you about it for
Okay,
sure.
perfect. Thank you
Good
so much.
question. Yeah, thank you. Yes, we are done. I don't see any other questions.